Now let's talk about high-yield facts in epidemiology. Assessment of disease frequency. The prevalence of a disease is the number of existing cases in the population at a specific moment in time. Prevalence means the total number of cases in the population at one point in time divided by the total population. The incidence of a disease is the number of new cases that develop in the disease-free population, also called the population at risk, over a given period of time. Incidence means the number of new cases in the population over a given time period divided by the total population at risk during the specified time period. Key fact: as the mortality of a disease decreases, the prevalence of that disease increases, for example, in type 2 diabetes mellitus. This happens because the duration of the disease becomes longer as people live with it for a greater period of time. Remember that prevalence equals incidence multiplied by duration of disease. Key fact: incidence can be measured in a cohort study, while prevalence can be measured in a cross-sectional study. Prevalence is directly related to both incidence and the duration of the disease. It is given by the formula prevalence equals incidence multiplied by the average duration of disease. For example, a chronic disease, such as type 2 diabetes mellitus, is diagnosed frequently, but because of improvements in treatment, people live longer with the disease. As a result, the prevalence of type 2 diabetes mellitus increases every day as more new cases are diagnosed and people with the disease survive for longer periods. When calculating incidence, it is important to subtract any pre-existing cases of the disease from the total population at risk because those individuals are no longer at risk of developing the disease again. Person time estimate. To further estimate the actual time at risk that all participants contribute to a study, a person time estimate is calculated. This is especially important in cohort studies because it accounts for the exact amount of time each person is observed before reaching a major endpoint. These endpoints include having the disease already at the start of the study, dying during the study, being lost to follow-up, or reaching the end of the study period. The person time estimate helps to provide a more accurate measure of how long the study population was truly at risk for developing the disease. Assessment of diagnostic studies. Sensitivity and specificity. Physicians use diagnostic tests to narrow down or confirm possible diseases. The sensitivity and specificity of these tests help determine how often false positive and false negative results occur. Both sensitivity and specificity are independent of disease prevalence. The accuracy of a test is usually compared to a gold standard, which is the most reliable and accurate test available for a particular disease. Sensitivity means the probability that a patient with the disease will have a positive test result. A highly sensitive test rarely misses people who actually have the disease. Therefore, it is good at ruling out disease when the test result is negative. A high sensitivity means there is a low false negative rate. High sensitivity is important at the early stage of diagnosis or in screening, when doctors want to catch as many true cases as possible and reduce the chances of missing any patients. Example: the initial ELISA test for HIV infection. The false negative rate equals 1 minus sensitivity, which means 1 minus the number of true positives divided by the number of true positives plus false negatives. A helpful mnemonic is SNOUT, which means sensitive tests rule out disease. Specificity means the probability that a patient without the disease will have a negative test result. A highly specific test rarely gives a positive result to someone who does not have the disease. Therefore, it is good at ruling in disease when the test result is positive. A high specificity means there is a low false positive rate. High specificity is most useful when confirming a diagnosis because it reduces the number of false positives. Example: the Western blot confirmatory test for HIV infection. The false positive rate equals 1 minus specificity, which means 1 minus the number of true negatives divided by the number of true negatives plus false positives. A helpful mnemonic is SPIN, which means specific tests rule in disease. The ideal diagnostic test is both highly sensitive and highly specific, but in most real situations, there is a trade-off between the two. When sensitivity increases, specificity tends to decrease, and vice versa. To compare the performance of different diagnostic tests, receiver operating characteristic (ROC) curves are used. In these curves, sensitivity is plotted on the y-axis and 1 minus specificity is plotted on the x-axis. The best performing test will have a curve that hugs the top and left sides of the graph, indicating a larger area under the curve and higher diagnostic accuracy. Clinical cases. Question 1. What happens to the positive predictive value, PPV, and negative predictive value, NPV, when prevalence decreases? Answer. When prevalence decreases, the positive predictive value decreases and the negative predictive value increases. Remember that if the prevalence of a disease is low, even a test with high sensitivity or high specificity will still have a low positive predictive value. Question 2. A local child care center built before the 1950s was found to have elevated lead levels in its paint. A student organization at your medical school is hosting a lead screening event to test all children at the center. Which initial screening test would be more appropriate? A test that has high sensitivity or one that has high specificity? Answer. A test with high sensitivity, such as a fingerstick lead test, capillary blood, is preferred for initial screening. This ensures that no children who might have the disease and who could benefit from further testing and treatment are missed. Children who have a positive fingerstick test should then have a confirmatory serum blood level test, which has higher specificity. Question 3. Your hospital is considering adopting a new diagnostic test for pheochromocytoma. In the current diagnostic test, urinary metanephrines falls close to point B, while the new test falls closer to point A. How will the false positive and false negative rates of this new test compare to urinary metanephrines? Answer. The false positive rate will increase because the test captures more people who do not actually have the disease, but the false negative rate will decrease because the test captures more people who truly have the disease. And this change corresponds to increased sensitivity and decreased specificity. Positive and negative predictive values. Once a test has been performed and a patient's result is available, the result must be interpreted using predictive values. Unlike sensitivity and specificity, which describe the test characteristics, positive predictive value, PPV, and negative predictive value, PV, depend on both the test's accuracy and the prevalence of the disease in the population. Positive predictive value, PPV. PPV means the probability that a patient who has a positive test result truly has the disease. When the disease prevalence increases, the positive predictive value also increases. A change in the test cutoff point that increases the number of false positives will decrease the PPV. This means that if the specificity of the test increases, the positive predictive value also increases, and vice versa. Negative predictive value, NPV. NPV means the probability that a patient who has a negative test result truly does not have the disease. When the disease prevalence decreases, the negative predictive value increases. A change in the test cutoff point that increases the number of false negatives will decrease the NPV. This means that if the sensitivity of a test increases, the negative predictive value also increases, and vice versa. Likelihood ratio, LR. The likelihood ratio expresses how much a test result changes the odds that a disease is present or absent. It shows how likely a specific test result is in people with the disease compared to those without it. Positive likelihood ratio, LR positive. This shows how much the odds or probability of having the disease increase if the test result is positive. Formula: likelihood ratio positive equals sensitivity divided by 1 minus specificity. Negative likelihood ratio, LR negative. This shows how much the odds or probability of having the disease decrease if the test result is negative. Formula: likelihood ratio negative equals 1 minus sensitivity divided by specificity. The relationship between these values is expressed as post-test odds equals pre-test odds multiplied by the likelihood ratio. This helps clinicians move from an initial estimate of the probability of disease, pre-test odds, to a more accurate estimate after obtaining the test result, post-test odds. Measures of effect. A central goal of epidemiology is to determine the relationship between exposure and an outcome. The likelihood or risk of observing an outcome after an exposure is measured using different measures of effect. These measures help describe and compare risks between exposed and unexposed groups. Absolute risk. Absolute risk refers to the incidence of a disease, that is, the probability or rate at which a disease occurs in a specific population over a period of time. Relative risk, RR. Also called the risk ratio, relative risk expresses how much more or less likely an exposed person is to develop a disease compared to an unexposed person. It shows the strength of the association between an exposure and a disease and is mainly used in cohort studies. Formula: relative risk equals the incidence in the exposed group divided by the incidence in the unexposed group. If the relative risk is greater than 1, this suggests an increased risk associated with the exposure. If the relative risk is less than 1, this suggests a decreased risk or protective effect. Attributable risk, AR, also called the risk difference. Attributable risk measures the difference in disease risk between the exposed and unexposed groups. Formula: attributable risk equals the incidence of disease in the exposed group minus the incidence in the unexposed group. To express this as a percentage, attributable risk percentage equals relative risk minus 1 divided by relative risk multiplied by 100. This shows the proportion of disease risk among exposed individuals that can be directly attributed to the exposure itself. Absolute risk reduction, ARR. Absolute risk reduction measures the difference in risk that results from an intervention compared to a control. It represents how much an intervention reduces the chance of an undesirable outcome. Formula: absolute risk reduction equals risk in the control group minus risk in the treatment group. In terms of a 2x2 table, absolute risk reduction equals C divided by C plus D minus a divided by a plus B. Number needed to treat, NNT. The number needed to treat indicates how many individuals must receive a treatment for one patient to benefit. Formula: number needed to treat equals 1 divided by the absolute risk reduction. A smaller NNT means the treatment is more effective. The odds ratio, or, is an estimate of the relative risk that is used in case control studies. It represents the odds of exposure among cases compared to the odds of exposure among controls. The odds ratio indicates how much more likely it is that a person with a disease has been exposed to a particular risk factor than someone without the disease. When the disease prevalence is low, the odds ratio closely approximates the relative risk. In case control studies, the odds ratio also describes how many times more likely an exposed individual is to develop the disease compared to an unexposed individual. Formula: odds ratio equals the odds that a diseased person was exposed divided by the odds that a non-diseased person was exposed. Once a diagnosis has been made, it is important to describe the prognosis, that is, how long patients survive or remain disease-free. Survival analysis summarizes the average time from an event such as diagnosis or the start of treatment to an outcome such as death or recurrence of disease. This is often illustrated with a Kaplan-Meier curve, which shows how the probability of survival decreases over time as patients die or leave the study. The hazard ratio, HR, is an estimate of the likelihood that an event will occur in the treatment group compared to the control non-treatment group. It is primarily used in prospective studies. An HR value less than 1 indicates that the treatment group has a decreased event rate, meaning the treatment is beneficial. An HR value greater than 1 indicates an increased event rate, suggesting a higher risk or poorer outcome in the treatment group. An HR value equal to 1 means there is no association between treatment and outcome. Formula: hazard ratio, HR, equals hazard in treatment arm, hazard in control arm. Clinical case: assume that the data below are from a hypothetical case control study. The goal is to calculate and interpret the odds ratio. The table shows that among the cases, 283 individuals were exposed and 263 were not exposed, while among the controls, 182 individuals were exposed and 210 were not exposed. The formula for calculating the odds ratio is the product of A and D divided by the product of B and C, where A represents the number of exposed cases, B represents the number of unexposed cases, C represents the number of exposed controls, and D represents the number of unexposed controls. Substituting the given values, the odds ratio equals 283 multiplied by 210 divided by 263 multiplied by 182. Solving this gives 59,430 divided by 47,866, which equals approximately 1.24. Therefore, the interpretation is that the exposed group had 1.24 times the odds of having the disease compared to the unexposed group. This means that exposure increased the likelihood of developing the disease by about 24%.